So I'd like to introduce our last keynote for this session, Dr. Shiela Cook. Shiela is the Director of Endocrinology and Diabetes at Toowoomba Hospital. She is the first endocrinologist to move west of Brisbane and has established the Diabetes Service and Obstetric Medicine Service in the region. Her commitment to patients and primary care in the rural areas has led her to develop the Physician in Practice Clinic, where she has provided care to patients and their GPs in their practice in Toowoomba and 10 towns in the Darling Downs. Seeing the benefits of telehealth to her patients, it has become a key part of the diabetes service in the Darling Downs. She has 4 children and has just started her PhD. So good luck with that mix. Please welcome Shiela. There's your slide clicker.
Thank you very much. All right, thank you. And thank you for the organisers allowing me to speak. So, as you can see, following on from Poppy and Adam, I've got big shoes to fill, but I think I also share the passion for innovation and new ideas. And I presented this presentation earlier this year in the National Diabetes Conference, and I thought I'd be amongst friends and a lot of other people doing the similar things. But I think around Australia, diabetes is taking a little while to get momentum. But similar to cardiac disease, everyone has diabetes, and so everyone in the rural areas need better care. And so I really wanted to talk to the role that telehealth can play in improving the access for patients in rural areas to diabetes care. So my definitions around telehealth, really just talking not so much tele-monitoring, talking very much about the public health perspective, talking to patients using telecommunication and video conference hookups for patients in rural areas. So this is the WHO definitions for telehealth versus telemedicine. So I'm talking about telehealth very specifically and looking at ways of accessing healthcare for patients and people in rural areas. So, similar to what we've heard already from Adam, what is the problem with being in rural areas? So this is actually not far from where I live, so I think rural areas are a great place to live. But, we know from, and this is national data, but looking very specific to Australia, patients who live in rural areas have certainly lesser health outcomes, and it relates to not just lack of access to healthcare, but the distances, of course, but also overall lower levels of education and access to household income, but also higher rates of disadvantage on that level, but also lack of access to public infrastructure as well. And when we think about the politics around health and funding, we think very specific, it's very much around what's happening in where the people live. And of course, most people live in Australia in major centres, and most of the specialists also live in such centres, so either in major cities or in regional areas. But of course, we've got a lot of people living in more rural and remote areas, and whether or not the healthcare services stretch out to those areas. We've already heard from Adam to looking at the challenges in Longreach and places like that. But then when you look at morbidity and mortality, so again, this is Australian data, and each of the colours represents where people are living. Metropolitan areas and inner regional, outer regional corresponded to the colours here. So as you get further away from major cities, you can see the health outcomes are worsening. And for my purposes, looking at diabetes relating to morbidity and mortality, the diabetes problem is certainly very pronounced in rural and remote areas. And so not only just morbidity, but certainly mortality is much higher. And this is not just Indigenous people. We're talking about, all spectrum of backgrounds. But you can also see that if you live in rural areas, the likelihood of dying in a transport accident is higher as well. So it's, much more dangerous. Whether you're driving a tractor or a truck or a car, it's not looking so good for you. So keeping that in mind when we think about people travelling to see us in our offices, we need to appreciate that there's risks associated with that as well. So when I looked at diabetes and prevalence and thinking, well, surely we're going to see higher rates of diabetes in rural areas, and it just doesn't pan out at all. So the more remote you are, you think, oh, gee, it's exactly the same as if you're in, downtown Brisbane. But that's probably not the case, and I think it tells us about the lack of screening in rural areas. But if you come from a poorer background, the likelihood of you having diabetes is much higher compared to those people from a higher socioeconomic status background. But the other big problem in Australia in diabetes is not just the fact that you have it, but the fact you don't get access to care for it, and I think that kind of makes sense. But there's certainly lower levels of screening, as I've alluded. But the people who actually have diabetes, 60% of people in rural areas actually don't get any more follow-up, and it's actually more pronounced if you're more remote from a major centre, and for those people who are in younger age groups. And so the likelihood of actually having follow-up is even worse if you've got poorer diabetes already. What we need to look at as the challenge in front of us in terms of diabetes is, how do we improve the care for patients in these rural areas with such poor outcomes? All right, so diabetes, now I was sitting there listening to Adam going, gee, how can I improve my services for diabetes? And unfortunately, unlike, a stress test, you can't just dive in there, do your test and just duck out again. In diabetes, it's all about the relationship and the partnerships we build, not just with the patients, but the healthcare providers. And it's all about the complexity of the disease. So it's a lot, when I go to my clinic, I'm asking all sorts of very detailed, intimate questions. I think most GPs clearly be doing that as well. But when I talk to my basic training physician colleagues, I say, now tell me about their sex life. Tell me about all these different, very intimate, personal interactions. Now, cardiology may do that. I don't know, but certainly not in a stress test. I'm pretty sure we don't get to that level of detail. But it's actually all about that communication and being able to engage with these patients over a period of time. So the idea is engaging patients to build up that rapport and actually improve their own self-management. So we're talking about lifestyle changes, we're talking about lots of medications. There's an awful lot to talk about. In our clinics, there's an awful lot of patients as well. So how do you then improve the way that we provide care both to those patients there, but maybe outside, out in the communities? So the other problem is that patients actually don't hear what we say. And I think, I went back to look at some of the the data on diabetes, and it's very little. So the literature that I'm really referring to is in terms of communications, GP, general practice literature. But when we look at complex communication, patients only really recall maybe 10% of a consultation. And if you have instructions, and I always have lots of instructions, they only got to remember one of them. So I'm really racking my brain trying to work out what's the one key message that's going to make the biggest difference to this individual, and how they're going to remember it. But the thing that really worried me is thinking a lot of these patients I'm seeing in these more, coming from rural areas, or if they've got a financial or educational disadvantage, they're even less likely to remember what I've said. So, people are less likely to recall things if they come from that background where they've had a poor level of education, if I've given them too many instructions, and if they're not getting follow-up within 2 weeks. So the idea that in diabetes land, the likelihood is you're going to get an appointment again in about three months, maybe 6 weeks if you're lucky, but certainly not two weeks. So, when we go back to, okay, if you're going to have a good consultation, what does that look like? What's the best kind of communication? So the things that predict a good conversation is if you've got a doctor or a healthcare provider who's got good communication skills in the first place. And the other thing, which is I think actually increasingly important when your level of education and financial background is even, going downhill, the context is even more important. So being familiar with the healthcare provider, understand, and being a familiar environment is even more important, although there's really not much data to prove that. But certainly there's some early information from GP literature to suggest that social gradient from GP or doctor down to the patient, and if the wider that is, the poorer the communication and poorer the ability for patients to get much out of it. So if a patient perceives the doctor or healthcare provider as being, distant or they don't have the same communication style, in a similar way to what Poppy was describing earlier, if you don't have that kind of contact and that relatability, that communication gets poorer. So if you've got someone who's got a social disadvantage, they're less likely to provide the doctor with information. They're less likely to be examined by the doctor, which I think is really interesting and disappointing. The patient, to a person who's got poor socioeconomic background, is less likely to provide information, and there's less likely to achieve understanding of that information, but also lower level of motivation to get on and do something, and less level of satisfaction with that consultation as well. So it really kind of brings back to me when I talk to my colleagues in Brisbane about how they communicate with patients, and how well does it go. They kind of look at me blankly, and I go, well, hang on, maybe communication really is the domain of the GP, and maybe better in their own location rather with a specialist. Okay, so then if you think of let's just say we go down the Princess Alexandra Hospital and go to a diabetes clinic. You know, when you're seeing the patient in the clinic, you know, you can perform that physical examination. There's a lot of non-verbal communication, and then the patient can actually see the whole team in one hit, and that all sounds very good. But we own the process, so it's, you know, we can make sure it's familiar and we know that we're getting everything done. But again, my question, do the patient actually hear us when we're speaking to them? You know, the patient experiences it as a very stressful experience. We had one patient, when we actually did psychometric testing to understand what it is that he was, you know, having troubles with his diabetes, he had a number of different consultations with our psychologist to do neurocognitive assessment. And where he started out looking like he was going to go, you know, into domain of dementia, you know, his level of recall was so poor, you know, we thought, gee, he's really suffering the diabetes consequences of regular hypos. He kept coming back for subsequent visits, and his memory and recall improved every time he came back for it. And then the psychologist, her assessment was that the stress of the travel, the car park, the admin officer, you know, making the appointment in the first place was so stressful that he remembered nothing of the appointment. So, you know, I just thought, geez, you know, how many patients are we really, you know, failing in this? So, you know, these patients, maybe they're not hearing as much as we think. So I think it, you know, reminds me of this cartoon that, you know, we're the doctor here. Okay, Ginger, I've had enough, you know, and then, you know, the patient or, you know, the dog in this situation, blah, 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 Ginger, blah, blah, blah. And I have a feeling, I look at my patients going, I feel like you're the dog and I'm this kind of pointy doctor talking at you. So, you know, replace that then with a telehealth experience. So, you know, similar to what Adam was talking about, where you've got the patient and the doctor at the other end and then the specialists, you know, engaging there. So this is the telehealth scenario where really you're engaging in an existing relationship. You're popping in, it's a context which is familiar to the patient, the conversation, the people are all happy and know each other. And then, you know, as a specialist, we pop into that conversation and add more information. So we support the GP to provide that care already. And so you really have everyone on board, the patient, the practice nurse and the GP all in the one consultation. And so therefore early follow-up. So if I've given 10 instructions, you know, the patient remembers one and then subsequent visits back to the GP, there's the opportunity to build on that, you know, that consultation. Okay, so telehealth. So when we've looked at, you know, a lot of the doctor colleagues that I discuss this with, they think, oh, gee, patients don't really take much of that in, you know, how good is it? And so there's a data that come from a number of studies in the US where the patients actually report a very high level of satisfaction, not just telehealth, but also digital technology. They actually prefer that and trust it much more than I think doctors in similar studies would have expected. And what's interesting in these telehealth studies, and there's a couple of big studies on type 2 diabetes, where the patients were much more likely to engage in the lifestyle changes that the doctor had recommended, and glucose monitoring much more than if they went to the specialist clinic. So they compare the two, and the telehealth wins every time. The HbA1c is no worse, so, you know, in terms of achieving glucose control, it's not inferior. But the patients, and this is in type 1 diabetes studies, they found that the kids were less likely to, or they were more likely to attend the clinic, and therefore there was, because it was just around the corner at the GP practice, there was less time off school and work. And so they're much more likely to attend next time. And overall, the diabetes knowledge was much better than those attending a traditional diabetes clinic in the city. All right, so really the outcomes for diabetes and telehealth were much greater in when the patients were in rural sites and when there was type 2 diabetes, but particularly when there were other people involved, so the practice nurses, or if there was telemonitoring, so people could actually engage with technology at home to bounce ideas off their healthcare providers centrally. All right, so I was asked at this presentation earlier this month talking about what are the benefits and what's the financial implications for telehealth compared to a traditional clinic. So I mapped it right out, looking at all the different consultations. So there's a specialist rebate that you might expect. With telehealth, it's a 50% increase on top of that, and so the service, the hospital itself gets, you know, these types of payments on top of. So instead of getting, and there are consultations for less than 10 minutes as well. So there's actually payment for all of those services far beyond a traditional clinic. But the thing that really surprised me, that every time that I sign off a patient travel subsidy scheme, so they've come in from, say, Longreach, and they sign off that form, when it's averaged out per patient, this is how much the hospital is paying per patient to pay that money out. Even though the patient may get $120, this is the money that's paid out by the hospital to accommodate that subsidy, which I think is fantastic for the patients, but a huge drain on the hospital in terms of managing those patients. So in terms of cost effectiveness, so I will come back to that in terms of the scenario of the patient clinic itself, but if you think then of the cost effectiveness, the only study that I could find, I have to proudly say, is one that was reported from Toowoomba. It was a pre-admission clinic, and so they're looking at telehealth appointments compared to a normal appointment for pre-admission, and looking at almost 1,500 patients. When they costed it out, there was an average saving per patient in the order of $57 per patient. So in terms of the payment comparison between, in a similar way to what I've just described. So that was the benefit to the hospital. But in terms of the travel payments, and these are the patient subsidy, that's how much money was saved per patient. And overall, 500 Ks of travel per patient, and a total of 6.5 hours per patient was saved just by doing the telehealth. And then you think about that times this many patients over that period of follow-up, it really is quite significant if you think about it. But in terms of patient satisfaction, there was certainly a high level of satisfaction that was reported in that study. All right, so if I take you then to my clinic this afternoon, and we just pretend in the clinics, say the patients that I might see, apart from the patients seen by other members of my team, let's just say 7 of the patients have come in from up to 2 hours away, and this is how many patients we might see. 4 of them have brought in their forms to sign off for the patient travel subsidy scheme, and people in the car parks and staying overnight. Let's just have a look at the conventional clinics. So if they come in and physically see me, this is how much money we might expect to earn from those patients, but then we have to pay them back $2,600. So we actually run at a loss per clinic of almost $1,300. Compare that then to the telehealth clinics. So we actually get the rebates for the new and the review, but then there's no PTSS payments because we're doing the telehealth, and we actually make a revenue of almost $2,000 for that small clinic. And if you compare that, there's a loss that way, and let's just pretend we pay that extra revenue into the video camera just once, so we get a net gain of that much money. So really the difference overall, so making a loss versus a profit, there really is just nothing to compare telehealth compared to a traditional clinic appointment. All right, so what about the patients? Well, the patients, let's just pretend each one has to pay at the car park. Now, I think it might be even less, well, certainly less than the Royal Brisbane. I don't know how much your car park might pay, much higher than that. I presented this to the people in Sydney, and they go, wow, that's so cheap. So let's just say, let's just pretend they paid $60, and they had to stay overnight, so let's just say $250 for the hotel for that cost. And so, per patient, it's not a cheap experience, and we've already said that, the social and financial disadvantage is pronounced in people living in remote areas. But of course then it's time off work, the wear and tear on cars. I've got people who can't drive themselves, they've got friends who have to drive them in, so they actually tell me it actually has a negative impact on their relationships at home, having to come in for repeated visits, and of course risk of the MVAs that we talked about earlier. Compared to if you just have to pop around the corner, or maybe you have to drive in from town, coming in, from out of town to do a telehealth visit is a totally different experience. And I've got one patient, I actually visited him and his GP in Tara, which is about 2.5 hours away, and I realised why I was actually having such a negative impact on him, because I had to park the car out front of the GP practice, so I'd go and visit him, and then came back out and had to walk past the pub, and he'd actually get drunk every time he'd come and visit me through telehealth. So I think we have to try and work out the home telehealth rather than the GP telehealth, because it was a real positive thing to come to the hospital. So for him though, and for the patients, less time off work and school, and they do come back, and the fail to attend rates are much less for telehealth, just because it's just so much easier. All right, so what's required? Well, this is obviously not me, but someone like me, that you need the camera and all the the equipment, and all I've already said, it's about $650 all up. And for the requirements for the funding, the patient needs to be 15 k's away or more, so that's no trouble for us. I would prefer that all telehealth clusters, the practice nurse, the GP, and everyone involved in the care of this patient in this GP practice, and that really does provide that education, the upskilling of the whole team. Okay, so for us, you know, what do we need to kind of make it happen? It really is the admin support, obviously time scheduling and sticking with that. And all we need is really, you know, current pathology and the glucose record when it comes to the diabetes management. And so that's all fairly straightforward, and it's all about the admin support. All right. So in terms of the telehealth, you know, again, I can't stress enough the importance of an admin support. So we've actually had our admin person who supports our usual diabetes service, does a lot of this work for us. And so we didn't get any new funding, so we started from zero and we've continued on with that. We've got a wonderful person who's very positive, and she does a lot of the reminders and works in great partnership with GP practices. So she does all the scheduling and the compiling of all the paperwork in preparation for the clinic itself. And we do have a dedicated telehealth session, like a clinic every week, but then we also have telehealth in amongst our normal clinic visits as well. So we'll have them scheduled at the beginning of our clinic as well, but we commit that time. So for our service, you know, it really is an imperative, and if it's just dialing down. So I'm one of 2 endocrinologists here now at Toowoomba Hospital, and we've got 20 facilities that we support, and obviously plenty of GP practices. And as we alluded earlier, I used to have a physician, the practice clinic, where I'd physically go and visit all of the GP practices that I could, and so I was doing that, you know, every week, and so I covered 110 GP practices, 110 GPs regularly. And a total of 35 practices all up over that period of 5 years that I was doing it. But then after baby number 4, I couldn't do it anymore, so now we're doing telehealth and looking at doing outreach services in the same way, but and being a little bit more targeted in who we can manage. But when I looked at our own, our Darling Downs health service, you know, we are really dealing with people from a very low socioeconomic status background. So this kind of big half of the pie graph here is, you know, the majority of people in our group are from the lower socioeconomic quintiles. So almost 60% are in the most disadvantaged quintile, and we've actually got 75% of our communities are actually lower than the average you know, marker of disadvantage in Queensland. So we're, you know, really dealing with people who are from a very low socioeconomic status background. So it's really important to look at what can we do innovatively to support the existing structures that they participate in. So in terms of diabetes clinics, so we really, you know, feel like we're doing great work, but we're, you know, compared to, actually I think I'll take it to the next one. This is probably more important. From a telehealth perspective, we are here, you know, and up until, you know, the last couple of years, we were the ones leading the state in terms of telehealth visits for diabetes, and you can see there's been a real improvement across Queensland and Metro North. You know, there's been some improvement there for Royal Brisbane to improve certainly getting up there with the number of visits. So everyone's really jumping on board with this. So really it's looking at telehealth as a regular part of our service. And so what we're now doing is a telehealth foot clinic. We're doing telehealth clinics all the time with our diabetes, but also endocrine and pregnancy clinics as well. So I suppose I just wanted to allude to my most recent venture is really doing telehealth regularly, but also partnering with public health programs in Cherbourg. So this is Cherbourg. And I was just going to say, I think the point of it is to go out and meet your team. So I physically go there every 6 months at least and do the telehealth in between times. And last time I went there, I went and did a clinic at the local medical health, the AMS, but also the Cherbourg Hospital, which is great. But then at lunchtime, I actually went to the school and did some education. So I took a whole big bag of vegetables and fruit and thought, let's go and talk about healthy eating with the kids, figuring, well, in Cherbourg, there's no food supply in Cherbourg whatsoever. There's a snack shop, but there's no groceries. So I thought, well, I'll take some food out to these kids and see what they know about healthy eating. So again, trying to talk about public health and being part of the community. So I figure if I'm going to be in Toowoomba and visiting Cherbourg forever, I might as well get involved with kids, you know, before they start getting diabetes and maybe help to prevent it. So meeting the team, I get out there and meet the practice nurses and the community. You know, it's all about trust and building that relationship and seeing, you know, how do they fit into their community and what role you can play in partnering with them. So in terms of the telehealth though, you know, we would see new patients. I'd prefer them to come in and physically touch and feel them if we can. And you're building that account, so you're building that relationship in the first instance, and then all review appointments thereafter at telehealth. But by the time you're doing review with the GP, you probably don't need to see them forever, and you can then discharge them quite happily to a team who's well versed in diabetes and management. And we just manage to support them and email a lot in between time to support that team with any questions in between. All right, so well, telehealth, in summary, it really is a way to provide access to specialist care in rural areas. You know, we know that patients accept it. I don't think clinicians are as enthusiastic, but it's bringing that on board. And if it's done through money, usual care is extremely expensive, and I do wonder how much benefit patients get out of it. And so by improving the quality of primary health care and those existing support mechanisms, I think patients certainly get much better care locally. And I've found for ourselves, it hasn't been particularly hard to set up. It's really the admin support to really get it going. All right, so I'll end with this. So we feel now it's cheaper to do surgery via Skype, so go home, lie down in front of your computer. All right. All right. So I think I've got plenty of time for questions. Any questions? Desperate silence. No, look, I think it's interesting. When I've spoken to patients, so I've got, because I went physically out to patients who I'd seen traditionally in the hospital clinic. So I think I've had an interesting spectrum of different patient contacts. So I'd had patients where I traditionally saw them in Toowoomba, and then I physically went and visited them, you know, out in their, you know, location. I did telehealth in their own hospital, which is a traditional method, so where you actually telehealth into their local hospital and then telehealth into the GP practice. And I've done that with a number of patients, you know, it's just how it's panned out. And the reflection they've given to me, and I was thinking I really should do the 5-star thing like Poppy did, you know, to get the feedback immediately. But I just asked them, you know, what do you reckon? Are you getting much out of this? Is this working? And I'm thinking about one patient in particular. She said, the only time I actually heard what you said was when I had someone familiar with me. I don't hear it when I come to the hospital. I don't hear it when I go to the local hospital, but I hear it when I'm with my GP or when I'm with my family. And she reflected, because it was a familiar environment, she heard it, and it was, you know, it was a terrific experience. So I have to admit to you, Shane, that I have done a little Skyping with patients. You know, because, you know, and there was one day I was sick and I did the Skype from my home, you know, so because, you know, we just thought we needed to keep in contact with those patients. So the reflection to me is the patient, it's all about the context, it was all about the environment. If it's not with the GP, it's their home. Absolutely, I think it's the way to go, particularly when we're talking about fairly intimate relationship stuff, you know, when you're talking about families and how they're coping. And if it's diabetes, it really is about that network of support. So I think if telehealth had access to home, as long as Queensland Health were happy to sign that off, you know, I'd be the first one knocking at the door. Mm-hmm.
Sheila, I've got a question. First of all, marvellous that you're working with GPs. I think that's really important, and I think it's been underutilised in telehealth. The issue we face there, we've improved connectivity significantly through the Queensland Health Telehealth portal. But I'm curious about scheduling. We all know that's a big problem, and particularly with a busy practice and a busy specialist. So how do you work around that?
No, I think it's a good question. So when they've embedded it in our clinic, you know, there's an awful lot of fluoro highlighter pen as low fires, that is. So, you know, we schedule it at the beginning of the clinic, so we know that we need to get there by a certain time. And, you know, because they're mainly review appointments, you know, we try and keep to that schedule as tightly as we can. I think all of us in our service are very committed to that. So I think having a, you know, an expected part of my day. But equally well, it happens that we put little, you know, bright cards on the patient file, so you know this is a telehealth, and you need to prioritise that over and above the patients who are sitting there waiting. So I think, you know, we just try and keep on schedule, knowing that the flow-on effect of, you know, these patients are waiting and waiting. So I had an experience recently where that didn't happen, and this is in our pregnancy clinic, which I don't know whether you've dealt with pregnant women very often, but they get pretty cranky when you're late. And so the downside, of course, is at the other end, you know, and I'm very mindful of this, having gone and visited, you know, the antenatal clinics around our area, you know, the knock-on effect of being late, you know, has such a negative implication for everyone. So where this poor patient had to wait, you know, 40 minutes because I didn't even know that she was even waiting at the other end, and there was no notification. So, you know, I then, you know, spend my entire afternoon texting her, you know, to make sure she was okay and we could answer any questions that way. So, you know, the flow-on effect was so negative, and I specifically asked her to make her and her healthcare service to make a complaint to our service to get up and listen so we could schedule that. And then I subsequently had a conversation with our team to make sure this didn't happen again. And I think, so it is scheduling, it is about notification of in lo-fi, you know, charts, because we're still chart-based, we're not electronic, so everything's there notifying everyone. And I think from a user's perspective, so from us, you know, not the customer, provider, to make sure that everybody, the clinicians, are absolutely clear about what the knock-on effect is, how many other patients behind that telehealth at that remote site have had to wait because you were late. So I think it's just being committed to that and recognising the benefit and the downside to not being on time. Yeah. So we and to be honest, so I love GPs, Dan, I know you're there. It's actually the practice nurses and the Indigenous health care workers that I've found incredibly important. So we often do the telehealth with those people as our priority. And so they'll get funded at their end as well. I think it's a different rate, but I think they'll still get funded. So if there's a need that I have for the GP at the other end, is probably just to make sure that there's a prescription written, you know, if we're wanting to have, you know, immediate action based on the plan that we have. If I write a letter, I do make sure it's as thorough as I can be and put point forms of the GP at the other end when they, you know, they can see what we were doing. So yes, the GP is critical, but I find that it's the other people who can serve that purpose beautifully, and in some cases better if the GP is not familiar with that patient.
Yeah, Shiela here.
Am I in trouble?
Over the time you've been doing it, I was looking at some of your slides in relation to the remuneration of general practice and into the private practices in particular. And that the trend didn't seem to be supporting the business models for private practices. Have you got a feeling of whether, since you've been doing this, the GPs in private practices that you are coming into by telehealth are increasing their interest? Have they plateaued? Are there barriers, and just how that's working over time?
Yeah, look, and I think that's a good point, because when I first opened, I physically, when I stopped doing the physician, the practice clinic, you know, early this year, I thought, look, I'm just going to really focus on telehealth, and we thought we'd just open up this Thursday and just make sure everybody knows about it, and we'd just wait. And we sat and we waited. So I think the GPs weren't necessarily, you know, keen to get on board, and I think it is about those barriers and the financial, you know, you know, I suppose it's making a loss really, rather than, you know, in some of the GP cases. So I think the practices that have come on board have been the AMSs who've specifically asked that we be involved. There have been the Stanthorpe crew who are always very positive, and so, you know, we're doing telehealth, and it's probably specifically the GPs who've got a good practice where there's a lot of practice nurses who've made it happen. So a lot of the other GP practices haven't kind of taken it up quite as enthusiastically. So again, that's where, you know, coming having a chat today to PHN to see whether they can, you know, fly the flag and support our, you know, our program as well. So I think making it happen in GP practices, I think the remuneration, I think the barriers are, you know, really about the support the GPs have to make it happen, and I think that's probably more of the barrier than we have locally at Toowoomba, you know, to make that, you know, a sustainable version of telehealth. I think my intention was to have telehealth that matched not just the clinic, but maybe a lunchtime session at that same time to bring together cases to we can just, you know, a case education, you know, that you've got cases to bring in. Let's talk about them as a community, you know, of interested GPs and specialists. So again, that was the next step really of pulling together, you know, not just the GPs, but rural hospitals and kind of case managing difficult situations around our district. So thank you.